I'd like to invite Dr. Manal. Dr. Manal El Sayed is a professor of pediatrics at the Ain Shams University in Egypt. She is the leading voice globally for the elimination of hepatitis amongst children. She's a hero of mine, and she's a champion as designated by the Coalition for Global Hepatitis Elimination this year. Dr. Manal, we're really honored to have you on. So thank you so much for making the time from Egypt, and the floor is yours. Thank you so much.
Thank you so much, Neil, for your kind presentation and for inviting me. And thanks to John, of course, and Lindsay and the whole team. I'm just going to give a very brief presentation, but I'm going to show you what we have done. Advance the slides. Okay, this is my disclosure. And if we look at this, that's of course the Polaris Observatory and Homi Razavi's work looking at the global estimated viremic prevalence of hepatitis C in women of childbearing age, and it's around 15 million women. And we know that women in childbearing age represent almost 1.9 billion of the global population. That's a huge population. And from our study also with the Polaris Observatory, we know that we have an estimated 250,000 children aged 0 to 2 years are infected with HCV globally. So this is really an important subject. And I think if we focus on women in childbearing age, we'll be able to advance elimination in a very short period of time. The countries with the highest number of total viremic infections are China, 16% of total infections, and Pakistan, 15% of total infections. But those with the highest viremic prevalence are Mongolia and Burundi. But the countries with the lowest might be Chile. According to WHO regions, the Eastern Mediterranean region, the IMRO region, and that includes Pakistan as well, has the highest viremic prevalence for hepatitis C in women of childbearing age. Of course, the prevalence increases with age. This is of course, the recommendation of CDC and the Advisory Committee for Obstetricians and Gynecologists, and we look at recommendations for screening of pregnant women. That's not happening in the majority of countries, and even when WHO recommended, they recommended triple elimination for hepatitis B, HIV, and STIs and syphilis, but they did not recommend screening of HCV, even in the countries with the highest prevalence and the highest viremic prevalence. So I think that's something that we should fight for and advocate for. And of course, it's an opportune possibility for treating women and linking them to care. So it's very important that we capture women during pregnancy. And I believe that it's an opportunity as well for the family approach and to capture the whole family and be able to screen and test the rest of the family if the pregnant woman is HCV positive, not only the children and follow them up, but also their partners and the other children in the family. So this is a study that we've done in Egypt, looking at microelimination of Hep C through testing of Egyptian pregnant women and linking them to care. And this study assessed the proportion of pregnant women who were screened for HCV at delivery in our hospital, at Ain Shams University Hospital. And we looked at the prevalence and risk factors for HCV infection, the adverse neonatal outcomes, and the real-life linkage to care of the infected women. As you know, we had this very large test and treat program in Egypt, and we started our study actually before the national screening program, but we had already the national treatment program that started in 2006, so anybody was allowed to be treated at any stage of fibrosis and at any time to get treated at a fully state-funded and supported by the state for hepatitis C. And of course, follow up the infants' HCV status and look at the timing of testing, the best timing for testing. The data were collected from the medical records of a retrospective cohort of all pregnant women admitted to our university maternity hospital for delivery between January and June 2018. We started our national screening program in October 2018. We collected data for 6,734 women. We've collected data for HCV antibody and RNA positive women and their infants were prospectively followed up. And we've done phone interviews until September 2019. And those were the results. Most of the women above the age of 30 years old, we had a history of abortion and blood transfusion were risk factors for hepatitis C infection. There was no difference in neonatal outcomes significantly between those who are HCV positive and negative women. And then all infants of the 13 anti-HCV RNA positive women who started DAA therapy tested HCV RNA negative within their first year of life. And we extending screening services, of course, to all pregnant women and better linkage to care are essential for national elimination. If we look here at the flow chart, we'll find that those were the numbers tested. Pregnant women who tested positive were around 1%, and pregnant women who tested negative for HCV RNA negative were 0.9%. Total pregnant women admitted to the hospital were 6,734. And those who tested negative for anti-HCV were 90%. And then out of the 19 women who were HCV RNA positive, we had 13 women who started DAAs. We did not start therapy for 4 women who did not want their infants to be screened, and we lost 2 women to follow up. And those were the times when we screened the children. 6 months, 7, 8 months, 2, 10 months, we screened 1, and 12 months, we screened 3. This is just an example of how we can link women to care and capture some cases. It was a mix of retrospective and prospective study and linking women who were positive to care and treatment. And I believe that none of those women who would have gotten treatment or received treatment for hepatitis C if they were not checked retrospectively and contacted. Most of them, they get very busy after they deliver their children and they finish their breastfeeding. Some of them, they breastfeed for 2 years and then they just completely forget about their HCV status. And I think that's our opportunity to capture those cases. And this is of course a study that was published in 2019 on universal HCV screening during pregnancy and its cost effectiveness. And we can see that universal screening of an average of 5 million pregnant women in 2018 could result in detection and treatment of an additional 33,000 women and 300 children born with HCV. So it's definitely cost effective to screen for hepatitis C. So just a few questions here. Why consider antiviral therapy during pregnancy? Potential to reduce the risk of mother-to-child transmission. We don't have a treatment before the age of 3 years, and now we are validating a PK study in collaboration with WHO for weights down to 14 kilograms. So that might be even less than 3 years old. They are likely to have routine antenatal care. So in HIV facilities or in all antenatal care facilities, we can have an opportunity to test those women. Pregnancy is often the time when women might have health insurance, opportune time to treat HCV concurrently with pregnancy care and would possibly decrease the risk of intrahepatic cholestasis of pregnancy. We've seen a lot of intrahepatic cholestasis of pregnancy in HCV-infected women in Egypt, and I think that's also another rationale to treat women during pregnancy. It provides an opportunity to cure HCV women with high-risk behaviors to prevent transmission to others, including injecting partners. And I think, and I believe, a unique opportunity for family screening and case detection in more and more cases. If we look at this study that we've done in collaboration with University College in London, and that's the HCV AVERT study, and it was for Egypt, Pakistan, and Ukraine. It was a cross-sectional survey for acceptability of HCV screening and DAA therapy in pregnancy. And we included all pregnant women above the age of 18 years who delivered within the last 6 months before the study. The questions included social demographic questions on pregnancy and HCV history and knowledge, women given fact sheets about HCV and pregnancy, and questions about acceptability of HCV screening and treatment in pregnancy, and motivation for use of DAAs for vertical to reduce vertical transmission and prevent mother-to-child transmission. And if we look at the results, we'll find that for the acceptability of screening, the acceptability was very high, more than almost 90% and even 95% in Ukraine and in Pakistan. And if shown to be safe, the majority said yes, they would accept to be treated during pregnancy to prevent mother-to-child transmission. And also in Egypt, around 30% said also to cure themselves of hepatitis C. So this study concluded the very high acceptability of HCV screening and DAA therapy in pregnancy overall, and 60% acceptability reported among non-pregnant women with chronic HCV in the US. That's in a previous study. The main motivation was prevention of adverse pregnancy outcomes, but I believe also because Egypt had already a large awareness and screening campaign and a program for testing. People were already aware of the importance of hepatitis C and treatment of hepatitis C, and maybe members of their family have been tested before and treated for hepatitis C, so that encouraged them and motivated them as well to respond positively to DAA therapy. We had a very large sample, and first to focus on pregnant women in high burden countries, and included women for a range of socioeconomic groups, so both HCV positive and negative hepatitis C. Limitations were measured acceptability under a scenario that they were approved for use. The findings support the need for phase 2 and 3 trials, of course, assessing safety of DAAs, and that's, I think we all agree on this. So I believe that we need to counsel women for the benefit of antiviral treatment before pregnancy. I believe that all children and adolescent females should be tested and treated very early during high school, and that would actually prevent the dilemma of trying to test them and treat them during pregnancy and issues about safety and conflicts about safety. This also looks at, this study also of ours that looks at 100 patients in our database from our national program who by accident were on DAAs, either soft DAC in the majority of cases, and all received 12 weeks regimen of DAAs, but some of them stopped 4 weeks later when they realized they were pregnant. But overall, even those who stopped treatment at 4 weeks or 8 weeks, they completely cleared the virus. And we've seen only a very small percentage with adverse outcomes in the babies, either as a preterm delivery or 2 abortions, and we had a congenital anomaly of atrial septal defect, which was not different from the general population. So the care pathway for HCV elimination and pregnant women and women in childbearing age should include universal screening with anti-HCV and reflex testing, HCV RNA once detected, assessment of healthcare provider for plan of treatment and DAA therapy postpartum and after breastfeeding. We were planning a study also for PK during breastfeeding. We started to collect samples, but unfortunately we lost a lot of women, and the majority did not turn up during the first 24 hours before stopping breastfeeding to be able to give them DAAs. So we did not achieve what we wanted to achieve for this breastfeeding study. I think this can be done in other countries as well. I would like to close with this final study, modeling study. I think it's first of its kind. Also, that was supported by NRS. It's part of the HCV AVERT study in collaboration with UCL. And that's just been approved for publication Journal of Hepatology. It's modeling for the potential effectiveness of hepatitis C screening and treatment strategies during pregnancy in Egypt and in Ukraine. And it's a pregnancy, considering that it's a unique opportunity to screen And there is a hypothetical cohort from 2 countries for screening and treatment strategies, 2 lower middle income countries with high HCV prevalence. The methods we used were country specific. The decision models, they were developed to simulate a cohort of pregnant women. We compared 5 strategies from S0 to S4, targeting either risk-based screening and deferred treatment to after pregnancy breastfeeding, or S1 WHO risk-based screening and deferred treatment, or WHO risk-based screening and targeted treatment, treat women only with risk factors for HCV vertical transmission, or universal screening and targeted treatment during pregnancy, or universal screening and treatment. Maternal and infant HCV outcomes were also projected. For the S0, that resulted in the highest proportion of women undiagnosed, both in Egypt and Ukraine. And for the S4 scenario, with the screening and treatment, it resulted in the highest proportion of women diagnosed and cured by delivery, and lower levels so that resulted in the highest proportion of women diagnosed and cured by delivery. So I think the conclusion from this very important model is that might inform future policies for potentially recommending universal screening or universal testing and treatment. And that's going to be my final slide.
Thank you so much, Manal. That was
thank you so much.